Okay, are you able to see the slide? My screen?
Yes.
Okay, so Anna and I were going to talk about not only TTP and pregnancy, but more so TTP in women of childbearing potential. So let's start with routine healthcare maintenance in women with the diagnosis of TTP. All women should follow cancer screening per the guidelines of general population, meaning there's not really a change on everyone getting their yearly pap smears, mammogram at age 40 or 50, depending on the risk factors, and colonoscopy in the same way at age 50 for everyone. And then regarding the vaccinations, everyone should get a yearly flu shot, pneumovac, a pneumonia vaccine for patients that are active smokers, have a diagnosis of asthma, COPD, or are older than 65. To our knowledge, there's really been no association between vaccines and being a risk factor for TTP relapse. We've been having questions about, if pregnancy is a risk factor for TTP, and the truth is that it is. We know that almost half of immune-mediated TTP occur in women of childbearing age, and pregnancy-associated TTP accounts for 12 to 25% of adult-onset TTP cases. Pregnancy is what we call a second hit, meaning when you have everything else, when you have sort of a borderline low Adams TS13 activity, and patients get pregnant, they may have, they are more prone to have a relapse while pregnant. And also in patients without a history of TTP, pregnancy have been known to be a risk factor for a new diagnosis of both immune-mediated and congenital TTP. The differential diagnosis, when a patient presents to the emergency room with the typical symptoms of TTP and the laboratory findings of low platelets and hemolysis, meaning this breaking of the red blood cells, is different in patients that are pregnant compared to women that are not pregnant. In pregnant women, depending at the time of the pregnancy, we need to take into consideration other diseases that may present similarly, not only atypical HUS, but also unique to pregnancy, such as preeclampsia or HELLP syndrome. When we look at the numbers of TTP, we know that it's more common in the third trimester, but also in the postpartum period. And other diseases that present similarly during pregnancy are much more common. So preeclampsia and HELLP syndrome are much more common than TTP during pregnancy, of course. So when we compare the clinical presentation and the outcomes of women that had TTP during pregnancy to women that had TTP while not pregnant, we know that the presentation is similar, meaning they'll present with the same symptoms and laboratory findings. However, some studies have suggested that pregnant patients have more cardiac involvement. They have the similar results, meaning the time spent in the hospital, the severity of the disease, and the mortality is the same. But it's been shown to be a risk factor for preeclampsia in future pregnancies. When we talk about are there any differences in the treatment of acute TTP during pregnancy? And the truth is not so much. We all use prednisone and apheresis. Prednisone crosses the placenta but appear in only small amounts in cord blood. As with non-pregnant women, pregnancy steroids have a risk of high blood pressure and diabetes, but there's no evidence of any fetal risk when used short-term like we do in TTP. And these we extrapolate from many other autoimmune diseases that use pregnancy during pregnancy, use steroids during pregnancy. Plasma exchange really has no other side effects when pregnant compared to non-pregnant patients. Rituximab, there's lack of safety evidence during pregnancy. It's okay to be given postpartum. There are case reports that Anna will discuss in more detail on TTP and other autoimmune diseases that have shown no adverse pregnancy outcomes associated with rituximab. And cabletzizumab, we don't really have any evidence when used in pregnancy. It is okay postpartum. Okay, now Anna, and I'll switch the slides for you.
Okay, thank you, Camila. So we are going to talk about the treatment or causes of TTP, but after the acute event. Sorry, can you hear well? Mm-hmm. Okay. So the Oklahoma registry published in 2004 published the risk of recurrence of subsequent pregnancies and what are the circumstances that provoke this initial event. So, and when they look at that, I want to first clarify, these are a small group of patients. We're not talking about hundreds of patients. These were in the 20s. But when they take a look at all the patients, they saw that when you have an initial episode that we don't, idiopathic is when we don't know what provoked the event, there is greater risk of recurrence when you are pregnant. When the initial episode was when you were pregnant, so for recurrent pregnancy, it was less, but it's not that it was zero. And when the initial episode was related with any drug induced or any drug related, if you stop the medication or the drug, then you will not have recurrent episodes during pregnancy. But as Camila mentioned before, in some period of the pregnancy, there are some overestimation of the rate of recurrence because sometimes it's confused with other disorders like gestational thrombocytopenia or gestational low platelets or preeclampsia or severe hypertension that can mimic this TTP but is not the diagnosis. Except in the first trimester, there is not too many confusing factors. So in the first trimester, if you present with low platelets and hemolytic anemia, then most likely is TTP. Next slide, Camila. So for some reason, the publications are not showing, but Schooley in the UK and also is a TTP registry published on 35 patients. This is, I think, is one of the biggest ones. And it shows that 50% of the patients will have recurrence in the subsequent pregnancies. And when they take a look about where in the pregnancy this TTP recurrence occurred, 46% of the cases were on more than 30 weeks or during the postpartum. 38% was 20 to 29 weeks, and less than 15% less than 20 weeks gestation. So if we look, it's mainly in the second, third trimester and postpartum. Next slide. So in that publication in the UK registry, they publish how they treat those patients. So if the patients were in remission, and we go to the orange part, if they have persistent low Azathioprine or levels, or they have positive antibody, what they do is they consider Rituximab, but before the next pregnancy, so it should be planned, the pregnancy. And if we go to the right side, that is all the green, if the patient was in remission and they have normal Azathioprine and negative antibody, was totally in remission, doing well, what they suggest is check the Azathioprine prior to the pregnancy to see where is the baseline, and then recommend to check monthly labs, regular labs, the platelets, the kidneys, the LDH, and then monitor the Adams TS13 in each trimester. Now, if the Adams TS13 decrease less than 10%, then you consider using a plasma exchange, steroids, and azathioprine. Now, what I want to mention or clarify is that we know that during pregnancy, in the first trimester, the Adams TS13 levels are normal, but then in the second and third trimester, it dropped to the levels of 30 to 40%, not only for patients with TTP, any pregnant patient. So this is why they said that if the Adams TS13 is less than 10%, consider plasma exchange steroids to prevent a new relapse. Next slide. So, and here I put a little about some preventive treatments, or you can use it in the acute event, and what we know about that. So, azathioprine is used in mainly patients with lupus. And based on the available information, there is no evidence that is associated with congenital malformation, spontaneous abortion, or stillbirth. So it's an option in pregnancy. The next one is cyclosporine. And I will add here that mycophenolate that came today in one of the questions, that also does not appear to have major human teratogenic effects or malformations, and could be associated with increased risk of prematurity. And the last one that I'm going to talk about, if you can change, Camila, to the next slide, is what happened with the exposure to rituximab. So the prescription package, or the recommendations today, are that they strongly advise to avoid pregnancy at least 12 months following the therapy. And next slide, I put here, there is some studies that they look at patients with different diseases: rheumatoid arthritis, lupus, ITP, immune thrombocytopenia, TTP, and lymphoma. And those patients, they received rituximab. And what time they received rituximab? So it was 6 to 12 months before being pregnant, and some of them, they received it in the second and third trimester. So, and what they saw is that 76%, they result in full-term deliveries, 24% of the babies born prematurely, but more than 30 weeks. And I mentioned some of they were given in the second and third trimester. And one of the problems is that the neonates, the baby born with low blood cell counts, and some develop infections due to the effect of rituximab. But after 6 months, they recover. From that group was one maternal death and one stillborn. So this is encouraging, but we need more studies to show that rituximab could be used during pregnancy if needed. Next slide. And I think with that, we can start taking some questions and see.
Yeah, I can start reading some. It says, I am 31 years old, have congenital TTP, have plasma every 3 weeks. My question is, if my platelet count is low when I'm going to get plasma, is there an argument for getting FFP more often or in higher doses than 2 units of FFP?
I can start, Camila, if you want.
Yeah, you can go ahead.
So when we look at the data from the UK, they recommend to, if there is any signs of acute event or the platelets are dropping, yes, to increase the frequencies of the FFPs. If you were getting every 2 weeks, then increase it to once a week and see how you are doing with that. I don't know if there is more data about increasing the dose, because what we don't know exactly is the amount of Azathioprine that we are giving with each unit of FFPs. So I think increasing the frequency, there is a little more data with that.
Second question is, after you give birth, will the diabetes from the prednisone disappear? Yeah, that's a good question, because unlike other diseases of pregnancy that have a similar presentation, for example, preeclampsia or HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelets, those diseases resolve with delivery. TTP, it's commonly seen in the third trimester, but also in the first postpartum period, and it will not resolve with delivery. And in the same way, the diabetes associated with prednisone will also not resolve with delivery. It will resolve after we stop the medication. So it's associated with the medication, not so much with pregnancy itself.
The next one is a clarification from my presentation. I think the teratogenic is when a medication or drug causes malformations in the fetus. I think I mentioned that, yeah, when there is malformations or causes in the fetus because of medication.
Do you know how many women were followed in the exposure to Rituximab pregnancy outcomes?
How many women? Yes, how many there were. So they start with, I think, 250 patients, and let me remember the study. I think it was around 50. I'm not 100% sure. I don't know.
Okay.
Sorry about that.
I think it's also a combination, because TTP is a rare disease. We extrapolate a lot from data obtained from other diseases that need to use prednisone for their treatment.
Yeah, you're right. So I remember that there were 5 or 6 patients with TTP in that group. Were not the majority, because the majority were patients with lymphoma. That also they use another chemotherapies in that group. That also is to take in consideration that Rituximab was given. So,
what is the explanation for ADAMTS-13 dropping in pregnancy for non-TTP patients? So pregnancy, especially in the last trimester, is sort of a hypercoagulable state as a response or as a preparation of the body for delivery, so that we don't bleed during delivery. And on that note, ADAMTS-13 drops, sorry about that. ADAMTS-13 drops slowly during pregnancy, can reach, I think, levels to 25-30% in the second trimester, and it's associated with endothelial changes during pregnancy.
So I can read the next one, Camila. Is, can you talk about hormonal birth control and endometriosis treatment that affect hormones as well as estrogen replacement therapy? Is there any general consensus on how estrogen or progesterone medication affect women who have TTP?
I don't think there's a consensus. I think that the general knowledge is that TTP is not sort of a, especially during remission, is not a procoagulant state. To my knowledge, I don't think there's any contraindication for birth control. And regarding endometriosis treatment, I think you can follow the guidelines of the general population. I don't know, Anna, if you have any other. I was actually looking this up before this talk, and I couldn't find any evidence, again, because TTP is such a rare disease. But I don't think that birth control, specifically estrogen-containing birth control, which is the more procoagulant, has been a risk factor for an TTP relapse.
Yeah, I agree. There is no information about that is a contraindication. And what I do in my clinic, I recommend my patients to have some type of birth control. Could be hormonal, could be IUD, because we know that pregnancy can have recurrent TTP. And I agree that there is no general consensus of this, which medication is estrogen, progesterone, one is better than the other.
Yeah. Yeah, and I would say that there's also not evidence of any risk factors or any risk factor for TTP for patients undergoing, for example, fertility treatment, that they'll be exposed to more hormones. As long as they're out of this acute TTP episode, they should be fine. The next question is, in your opinion, if we have TTP, can we still safely have a child? I think I would say for the most part, absolutely. I think that if a woman has a diagnosis of TTP, she needs to work closely with her hematologist. We know that pregnancy is a risk factor for future events of TTP. That doesn't mean that you can't get pregnant. It just needs to be something that needs to be monitored closely. It's very important to know, for example, the Adams TS13 activity before pregnancy. It's important to know the prior pregnancy history if the patient didn't have an acute TTP with prior pregnancies, but they had other thrombotic microangiopathies like eclampsia, preeclampsia, or HELLP syndrome. And if the patient decides to get pregnant, then a routine monitoring with their hematologist is vital to prevent a relapse. But I think that one can get pregnant, yes.
Yeah, and from my point of view, I always tell my patients that I will help them with a pregnancy. It's not a contraindications or anything. Now, if we take a look of the studies that published with patients, pregnant patients with TTP, the patients that they already have the diagnosis prior to pregnancy, those were the ones that had better outcomes, because we know and the monitor was much more closely and the monitor of Adams TS13. So the treatment was started much earlier, so the outcomes were better. So to answer the question is, I don't recommend, but it's not a contraindication. You want? I read the next question. At 30 weeks, I was diagnosed with iTTP. Now, 3 weeks postpartum, I have an acute TTP occurrence. Now my diagnosis is TTP. I want to have additional pregnancies in the future. Could I be most at risk in the third trimester? Would you suggest getting the fourth place for plasmapheresis before pregnancy, or just if needed? What prednisone dose is safe for pregnancy? So I think there is many questions. Do you want to start with some and I answer others?
Yep. So I think that, interestingly, when you say at 30 weeks, I was diagnosed with ITP now, and then 3 weeks for postpartum, you have a TTP occurrence. I wonder if what you had at 30 weeks was ITP or actually TTP. So I want to have additional pregnancies in the future. Would I be at most risk in the third trimester? Yes, I think so. Every woman with a diagnosis of TTP have a high risk factor of a recurrence in their third trimester and the early postpartum period. So that's the first 6 weeks after delivery. I don't know if you want to keep going, Anna.
So the risk is in the third trimester and postpartum. I will add that I will start checking labs and monitor the Adams CA13 in the starting in the second one, in the second trimester. And remember, since in the postpartum, we continue with frequent labs 6 weeks or even more, 8 weeks postpartum. The next question is if we suggest getting the port placed before the pregnancy, just in case. I will not recommend to have a port just in case. There is, remember, it's a foreign body, there is risk of infection, so I will place it only if needed. And it's more than a port, is to clarify, is a catheter, a big catheter, so it has even more risk of infections than the port.
Yeah, you don't need a port, like, you know how patients with chemotherapy for cancer, they get ports in their chest for recurrent chemotherapy. I think that for plasma exchange, we use like an isane central line, which is a big catheter. But certainly that's not something that we like to keep in the body for a long time. And I think that the key to get pregnant and have less complications during pregnancy associated with TTP is to stay on top of it, to try to prevent a relapse. So we don't want you to need plasma exchange during pregnancy, right? We're gonna suggest a close monitoring of the Adams CS13 so that we can look at a trend. And if it's trending down, we will consider maybe other medications that have known to prevent relapses, such as Cyclosporine or Azathioprine, instead of having kind of wait until a patient has an acute TTP and needs steroids and plasma exchange. And if you were, sorry, go ahead.
With the prednisone dose, say for pregnancy, is the same dose that we use in the acute event. And also start tapering. We don't like to keep the patients a long time with high dose of steroids because of the steroids or prednisone, sorry. Also, some they use dexamethasone, is another type of steroid, so prednisone, dexamethasone, but we don't like to keep it so long because of the complications and long-term complications, and especially in pregnancy that you can have gestational diabetes, you are adding the prednisone that also can cause high sugars. So we try to taper as soon as possible.
Mm-hmm. Yeah. Usually we start patients on 1 milligram per kilo of prednisone, but like Anna is saying, I think that key is to taper that fast, and I think that those have known to be safe. So then,
some others, sorry, Camila. So to add to that, some other physicians, they use they call dexamethasone, that is in much higher dose but shorter course. So is higher doses for 4 days, and then you can repeat it after a period of time. So those are the options that they are safe in pregnancy.
Mm-hmm. I would like to get elective surgery to remove a benign fibroid. Should I leave it alone since I've had 2 episodes? Or as long as my Adams CS13 is at the appropriate level, above 70%, is it okay to go ahead? How afraid of elective surgery should I be? I think that if the fibroid, I would first start with sort of the symptoms that you're having from the fibroid. Even though it's benign, uterine fibroids are associated with heavy bleeding during periods that may be very bothersome and sometimes cause anemia requiring iron. Some may cause fertility problems. So I think that I would start with the type of symptoms that you're having from the fibroid. If these symptoms are affecting your quality of life, for the reasons I've mentioned, I don't think it's unreasonable to go for surgery. It seems that your Adams CS13 is well under control. And if if there's been at least, 6 months to a year after your last episode, I think it's definitely reasonable to go under elective surgery. Again, as long as you're not on that acute period, I think that your surgery should be fine.
Yeah, I think it's a good point first to be more like after remission, and like 6 to 12 months is a good point. There is no guidance, and always contact your hematologist to check the levels. If your levels are normal, is a safe time to have a surgery if you need it.
Yeah, sometimes also, assuming this is a uterine fibroid, what we're talking about, you can, which is, for example, giving you heavy menstrual periods, you can also discuss with your GYN other options for decreasing heavy menstrual periods, such as a uterine artery ablation or different types of birth control that can help with that if you're concerned for undergoing surgery.
So the next question is, I will read it. I received Rituximab this past October as a chronic relapser to prepare for trying to get pregnant, but it does not seem to keep my Azathioprine levels up like it has worked well before. I am 38, so my time is running out to get pregnant. How do I know whether it is safe to go ahead? I don't want to miss out on something so important to me in life, but I want to be safe about it. So, one of the first questions that I will have is those levels of Azathioprine keep going down, or has been low but in a stable level? Second is, if the levels are very low and the Rituximab is not keeping your levels in a decent period of time, because what we need is 9 months, then we should consider other immunosuppression that is going to be safe if you get pregnant. So Azathioprine, Cyclosporine, mycophenolate, those are ones that I will do it before you plan to get pregnant.
Yeah, I would say that we've had some patients not only trying to get pregnant, but in other situations that we give them Rituximab and their Azathioprine don't go up as much as we were hoping to. So the use of Cyclosporine or mycophenolate is not something that it's unique to in order to give during pregnancy or in preparation for pregnancy. It's something that we use many times in patients that do not respond to Rituximab, or they just don't want to have had a side effect from it. And in those cases, we've had a really, really successful responses with Cyclosporine. Other idea, you say you're a chronic relapser. In patients that have had multiple relapses and even have had pregnancy associated, TTP associated with pregnancy in the past, but wish to become pregnant in the future, we've recommended splenectomies as an option to prevent relapses in the future. And after the splenectomy, patients have gone pregnant and have done really well. So that's something else that could be discussed with your hematologist and your GYN.
Yeah, I will first try the immunosuppression, especially to see if you can continue during pregnancy as a way to prevent relapses during pregnancy. The other thing is how long the effect of Rituximab is lasting. So I don't think that we have other questions, Camila.
No, not right now.
But I was so one of the important points I think we didn't talk about too much is about the difference between congenital and acquired or immune TTP in pregnancy. Is very, very important because the treatment is going to be different. And I think we have one of the questions about FFPs or plasma for congenital that is very, very important, especially in the presentation at pregnancy, to distinguish, because we need to know the treatment and how long it's going to be.
Go ahead, sir.
I don't know if you have any questions or any questions for me, but I want to mention about my patients in the clinic that the first important point is to have a high risk of be working with you. And if it's in the same institution, I think is important because we can collaborate and treat you patients in the same institution, and the communication is much better. So I think this is the first step, even if you are not pregnant, but you are planning to be pregnant, to have a high risk of be and a hematologist together talking.
Yeah, I wanted to also comment on what you said regarding the difference between immune-mediated and congenital TTP. One may think that congenital TTP is only diagnosed during in children that grow, older, and they already, by the time they're adults, they already know they have a diagnosis of congenital TTP. But that's not quite the case. I think that 30% of women made their first episode of congenital TTP during pregnancy. So as Anna is saying, I think it's really key to, when you have your first diagnosis of TTP, if you're pregnant, to make sure you actually have an inhibitor against the protease, against Adam's TS13, or this is actually congenital.
Yeah, in the session for the congenital TTP, it was mentioned about the two peaks in life about congenital TTP. One is when you are young, in the 3-4 years old, but the other peak is during pregnancy. I think it's part of the genetics that some patients they present early in life, and some others something triggered, that is the pregnancy, and you can diagnose or you diagnose with congenital TTP. And especially for future pregnancies is important. Sometimes it could be confused. Congenital TTP and immune TTP during pregnancy. For the future pregnancies, it is important to make this distinction. No more questions? Wow. So Camila, was your patients with TTP that they want to be pregnant, how you treat them or how you manage them?
So if I have a patient with a history of TTP that wants to get pregnant, I obtain an Adam's TS13 activity before pregnancy. And ideally, I think that the Adam's TS13 activity before pregnancy should be normal, so more than 40%. And if that's the case, they can get pregnant. And during pregnancy, we follow them actually once a month through the pregnancy. And that is if the levels continue to be normal. If we start, if before the patient wants to get pregnant, the Adam's TS13 is actually on the lower side, say between maybe definitely less than 30, we may consider cyclosporine as a preemptive therapy. And if not, we do even a closer monitoring, maybe every couple of weeks. And it's a discussion depending on what the patient wants. This is if a patient has had a diagnosis of TTP not associated with pregnancy. If the patient has had a TTP and pregnancy in the past, then we even may be more aggressive trying to prevent relapses and more aggressive with a follow-up, so even closer than every month, and just start them on cyclosporine sooner. Dr. Catalan just had a TTP patient that got pregnant with twins. and she did really well. She actually received Rituximab during pregnancy because her LMC13 activities were dropping. Everyone is safe and doing well. The babies were born early, which is not due to TTP. I think twins are usually born before the due date, but otherwise she did well postpartum. They measured the B cells, which is the cells that we suppress with rituximab. They measured them with the babies, and they had deficient B cells. So rituximab definitely affected them. However, they didn't have any associated infection with it, and I think after a few months they did well.
So when you mention about B cells, is to clarify that it's part of the white blood cells that they were low. And if you remember in the presentation, it was mentioned that the babies, they born with low counts, and this is what Dr. Masias was referring to. And before we read, there is one more question, is even though there is case report, I have a patient with successful delivery, and she and the baby are doing great with the use of rituximab in the second and third trimester. Mm-hmm. So the question is, have there been any findings on whether going off a long-term birth control could be triggered for a first acute episode of TTP? Camila, you want to answer? Or?
Yeah, I think there hasn't, to our knowledge, I don't think so. It's very interesting because we know that birth control makes patients prone to have clots, but the mechanism is obviously different from the one on TTP. But I don't think that going off birth control has been known for a risk factor for an acute episode of TTP.
Yeah, I don't have information about that neither. I don't know if you go off birth control and then you get pregnant with 3 years. That is different, but to answer to your question, I'm not aware that going off long-term birth control will trigger. So the other question is, have you heard patients say that after a TTP episode, their cycle has changed? I spoke with my doctor because my blood was thick and she put me on birth control. I have patients telling me that during the TTP episode, their cycle changed, but not after they become regular. So when we said change, is a changing for heavy menstrual periods or change less? I don't know, it could be, and I don't know the answer, that could be a hormonal disbalance because of the illness for the TTP that can change the menstrual period. Is a theory about that. Yeah. I don't know if you, Camila, has any.
I agree. I don't think I've heard that patients have changes in their menstrual periods after the TTP diagnosis. But I will say that oftentimes when patients have a diagnosis of TTP, they carry this diagnosis, and whenever they have a symptom that has nothing to do with TTP, if the physicians are not familiar with TTP diagnosis and treatment, they may attribute this symptom, for example, heavy periods or thick periods, to the history of TTP, but most likely it may have nothing to do with it. So I think it's very important that if, for example, in this situation, if the periods are changing, maybe they're becoming heavier, definitely the patient should start with having a workup like with any other patient without a history of TTP. So maybe a pelvic ultrasound, a transvaginal ultrasound, and making sure their hemoglobin is okay, and they're not iron deficient. all those things should be done, all that we should, just because we have a diagnosis of TTP, we should not miss all the very important routine things that we need to look for before attributing these symptoms to TTP.
Yeah, I think the first step will be talking with the GYN and see if there is any fibroids, or there is, as I mentioned, the hormones are balanced, to explain why the menstrual periods change. And sometimes they use birth control or hormones to control and regulate the menstrual period. So it is an option. I don't have any patients receiving birth control that they have with TTP, that they have clots. This is my personal experience.
Yeah, I think we are running out of time.
I don't know if anybody has a last question, can post it before we end this session.
And also, I think that, if you go into the USTMA website, you can find our information. You can always email us, reach out to where we work if you have questions.
Okay, yeah, you can email us or contact us in our site. I am from Emory University, and Camila is
I'm from Baptist Health in Miami, so we're in the south.
Thank you, Camila. It was good.
Nice talking to you. Let me, I think we'll, oh, there she is.
Hi. All right. Thank you guys so much. I'm going to go and promote our next speaker, Dr. Lyles. Thank you very much for your help and for this awesome session.
Thank you.
Thank you. Let me see here. All right. Are you there with us, Dr. Lyles?
I am.
All right, perfect. Are you able to turn on your video, or should I deactivate that?
I tried to turn it on. Let me see if I can again.
Oh, there you are. Beautiful. Let me pull up your slides here.